Good day, everyone. I'm Dr. Chanell Concepcion, and I'm your professor for nursing research NCM 51. So today we're going to talk about Module 1, which is the introduction of nursing research and evidence-based practice. So in this module, we're going to discuss the introduction to nursing research in an evidence-based practice environment. And also we'll talk about, this is a huge topic, but we'll just do a little bit of introduction on evidence-based practice, how you translate the research evidence into practice. So let's begin with some introduction to nursing research. I'm sure many of you in your senior high or maybe in your high school have had research, but for this course we'll talk about nursing research. So when you think about nurses, sometimes our imagination of nurses are those in the bedside or in the community taking care of clients, families, and different people in the community. But we rarely think about nurses as researchers. But more and more, it is expected that nurses will have to do research in this day and age. And research evidence needs to be the basis of our practice in nursing. And it's already an expectation for most nurses to adopt evidence-based research, whether they are in the practice setting or whether they are in the academe. So let's begin by talking about nursing research. When you say research, it's always a systematic inquiry, right? If it's nursing research, we are looking at generating evidence that is important in nursing, nursing as a profession, nursing practice, whether you're in the hospital setting, acute care setting, or the community setting, or whatever setting you are in, nursing education, and nursing administration, leadership, management. There's so many things there that are issues that are related to nursing and is an interest in nursing research, as well as informatics. So why is nursing research important? First here, it informs decision-making for patient care. So when we care for patients, there are so many evidences or authorities that would tell us what to do. Maybe it's also from tradition. But when we base our nursing care on research or evidence from research, it is more solid, more scientific, and it is expected to have better outcomes for the patient. And nursing is very important to solidify nursing as a profession. For quite a long time, nursing has been struggling with being recognized as a profession. And for us to defend ourselves as a profession, we have to have this body of knowledge. And this body of knowledge could expand and keep on growing if we add more knowledge into it. And that addition of knowledge, one of the sources is coming from research. Of course, if you want to advance in your career through credentialing and status and professional advancement, research is very important. And there's also the creation of new practice knowledge. So it's not just on, adding some credentials to our name or publishing papers because of our researches. It's really advancing nursing as a profession. And it drives changes in nursing practice so that we can have better patient outcomes. And it bridges the gap between theory and practice. So on one hand, we have theories that sometimes are not proven, and the other hand, there is practice. So what bridges the two is research. So you can prove that this theory has basis, has grounding when you do research, and it can be translated. So we can think about research in more of a consumer-producer continuum. In one hand, you're a consumer of research. Maybe you're a nurse at the bedside, and you wanted to make sure you give the best care by looking at the updates about a certain topic, for example. So you're constantly looking at clinical reviews or clinical trials or systematic reviews and things like that. On the other hand, you may be a nurse in the academe who has a lot of funding or required to do research, and you're a producer of research. You conduct the research. But many of us are kind of in between. We are not really doing research per se, but we are contributing to activities of research, such as contributing to a clinical trial, maybe gathering information, or advising patients to be part of a research study, just like the vaccine right now with COVID-19, and seek answers to clinical problems. Or we're looking at the merits of a research as an evidence in decisions that we're going to make, and maybe discuss the research implication. The history of nursing research is rather long, but we'll just look at some of the highlights. We always go back to Nightingale, Florence Nightingale in 1850, and probably you know about this in your foundations in nursing, where she collected data and presented it to make changes in the situations in the hospital or during the time when they were caring for the soldiers during the Crimean War. So really, research and maybe even evidence-based practice would be traced back to the age of modern nursing, the beginnings of modern nursing espoused by Florence Nightingale. But it took about maybe 100 years before the first journal emerged, the Nursing Journal, 1950. And then a couple of decades after that, there were clinical researchers that came out. And in 1986, this is in the United States, the NIH had established a National Center for Nursing Research, really recognizing the importance of research in the whole health research arena. And then in 1993, there was the establishment of National Institutes of Nursing Research. And then 20 years ago, 2000, they had a budget. That means there's already a very big recognition of the importance of research, and the budget and money are pouring in, about $100 million poured in for nursing research. Of course, this is in the United States. I'd like to show this slide because I'm really amazed with Dr. Linda Aiken and how much her research has impacted nursing, and not just nursing, but also the whole field of medicine and health. I took this picture in the ICN, International Council of Nursing Congress in Barcelona, Spain in 2017, and I was awed when I saw her personally and listened to her researches. And she did pioneering researches in many areas that has changed the way we look at nursing and patient outcomes. One thing that she's contributed is that nurses who are caring for fewer patients have better patient outcomes. So that's why some states and some countries are adapting the nurse-patient ratio. Like, for example, in some states, for example, in California, for inpatient, you will have one nurse for every 4 patients. In the Philippines, DOH requires one nurse to every 12 patients. Some people in the International Standard Hospital go crazy if you give them that ratio, but it was her research study that really contributed to that. Also, one of the groundbreaking studies that she did was she saw that patient outcomes improve when the nurses taking care of the patients have a bachelor's degree or higher. This was done in mortality among surgical patients. And this has revolutionized the way they're saying that nursing, if you educate the nurses very well, you have safer patients, better patient outcomes. That's why in the United States, their aim is to have 80% of all the nursing workforce to have a BSN. Here in the Philippines, we already have that as a standard. Okay, so also improving nurses' work environments are very, very important. So you can see how much the nursing researches can change the way we do practice or how we see nurses, the patient outcomes, and how we should look at the nursing workforce. So what is now our direction for nursing research? So these are the path forward. There is a continued focus on evidence-based practice. It's nothing new already. A lot of people know about it. They're adapting it. And then there's also an accelerated emphasis on research synthesis. So later on, when we talk about EBP, we'll be talking about systematic review and looking at the synthesis of these really robust study that would help us give quality evidence when we do decision making. And of course, there's an expanded local research in healthcare settings, strengthening interprofessional collaboration, increased emphasis on patient-centeredness. And this is a very important concept, especially in research. And related greater interest in how research can be applicable to our patient care, to our practice, and not just something like a theory that we wanted, not just basic research, but more applications research. And there's also a growing interest in defining and ascertaining clinical significance, that the research would do would be significant to the patients or the clients that we care for. And also, there's a growing interest of kind of a personalized care. The terms that have come out is precision healthcare, symptoms science, more personalized kind of care to our patients, and research is focused on that. Now we think about what are the sources of evidence for nursing practice, okay? So there are different sources when it comes to the knowledge and how we do practice. One of the more traditional sources is the traditions, what we've done. We've done this for many years. This is the way we've done it. And also the authorities, the expert in certain fields. Oh, Dr. whatever has said this, and I think she's an authority in this matter, so this must be solid evidence. Okay. There's also a clinical experience in trial and error. Some of the things that are decided in the clinical and the bedside are not found in the books. It's not something that you just open your book and look at it. There could be a trial and error method, and then that's how you learn from experience. Of course, there's logical reasoning, inductive or maybe deductive way. And you assemble information. In big hospitals, there's always one department that looks at quality improvement, and they collect a lot of data and they assemble this information to see how practice can be improved, or processes can be improved. And of course, one of the evidence for nursing practice is disciplined and systematic research. So if you look at the paradigms and methods of nursing research, we have to consider different ways of looking at things. So when you talk about paradigms, it's ontology and epistemology. It looks like these are very big words. If you have philosophy, this is probably familiar to you. But ontology is looking at what is reality, okay? And epistemology answers the question, how can I know reality? Okay, so when you're looking at these questions, these are age-old questions that maybe Aristotle and Socrates have thought about. This is what you call paradigms, the way you see things, the worldview. And these paradigms would influence the way you do the methodology of your research. So how you plan your research, how you would produce that knowledge, and also the methods. Sometimes we mix up methodology and methods, but when you say methods, these are the tools to collect the data and to analyze the data. So paradigms for nursing research. So when we're looking at that, there are actually two main paradigms in nursing research, the positivist and the constructivist, or the older name is naturalist. In many Pollitt and Beck books, they use naturalistic paradigm, but in the newer version, they use constructivism. Okay, positivism is a kind of paradigm that says there is a reality that exists. There is a real world driven by natural causes. The constructivists or naturalists say there are multiple realities. It's not just one single truth. It's subjective. It's mentally constructed by the individuals. So that's how they look at the world. In terms of looking at the subjects or participants, the positivists, usually they call themselves, they call the people they're studying as subjects. These are independent from those being studied. So you try to remove yourself from those people so that there will be no influence. But when constructivist naturalist, you interact with those people that you studied. Okay? You need to have a good rapport, good relationship, so you can draw out the data that you want. So just two different opposite way of looking at it. Values. So positivist, you have to put your values in check. That means what your opinions are, you have to set them aside. Okay? The objectivity is something that's very, very important in the positivistic paradigm. Whereas in constructivist and naturalist, subjectivity is something that is not frowned upon. Okay, the values, as a researcher, you have your own values, you have your own subjectivity, and that's desirable. You cannot avoid it. It's inevitable. Okay, so just a different way of looking at it. So if you look at this, what are the best methods for obtaining the evidence? If you look at the positivist perspective, then it's a deductive process. You have a hypothesis or maybe a theory, and you try to test the veracity or validity of that hypothesis, whether we reject it or not. It's objective, quantifiable, there's a fixed design. You have to have controls over extraneous variables. Usually it's desirable to have a big representative sampling or large participants, measured information. You need to apply statistical analysis, and after that you make a conclusion, a generalization. On the constructivist point of view, it's an inductive process. You're not testing a hypothesis. You may be generating hypotheses at the end of your research. And then they're subjective and quantifiable, flexible. The design could emerge as you go along. It could be context-bound. You have to consider the context. You don't need to have a big sample. A small sample is okay. Narrative information is what you want. And then the analysis of the data is using qualitative methods. And it seeks an in-depth understanding of the phenomenon that you're studying or the people that you're studying. Now, so when you look at the types of research and the different paradigms, you can see that positivist is aligned with quantitative research, okay? And qualitative research is more aligned with constructivism or naturalism. We will talk more about that in the succeeding modules. But in nursing, of course, we have to really understand this multiplicity of paradigm, different, multiple paradigms. It's viewed in the lenses that help us sharpen our focus about the phenomenon. These are not blinders that limit intellectual curiosity, but it makes us to understand the different colors of the world, different realities out there. So if we look at the purposes of nursing research, we are concerned with answering some of the questions that have relevance and that have significance in nursing profession, right? So basically there are two types of nursing research. One is basic and one is applied. So basic, you wanted, like we said, we are a profession, we wanted to expand the body of knowledge, we need to add to that body of knowledge. Or maybe at the end of the research, you wanted to formulate or maybe refine theory. Okay? For applied research, you're focusing on finding solutions to certain problems, especially it's a clinical problem or it may be an academic problem or a management problem. And it tends to be greater immediately utilized in the evidence-based practice arena. So it's very well connected with translating evidence to practice. So if you look at the specific purpose, these are the purposes of nursing research: identification, description, exploration, prediction, control, and explanation. All right, so quantitative, for identification, it's qualitative research, identifying the phenomenon. Both could be descriptive. Both types of research, quantity and qualitative, could be exploratory. But if you want to predict and control, then that is the quantitative research framework or paradigm. Explanation could be both, right? So it has the same purpose except for identification and prediction and control, but the methods and methodologies differ. Okay, so that's the introduction to nursing research. Let's have a little bit of a discussion on evidence-based practice and translating research evidence into practice. Okay. Now, let me start with a question. Okay. Tell whether the following statement is true or false. The use of study findings in a practical application unrelated to the original research is called or is termed as evidence-based practice. What do you think? Is it true or is it false? I'll give you a few seconds to think about it. Okay, well, the answer to that question is false. So research utilization is the use of study findings in a practical application, but it could be unrelated to the original research. Evidence-based practice is basing clinical decisions on best possible evidence, and we'll talk more about what the best possible evidence is. Okay, So here, just to make sure that we are clear that evidence-based practice is different from research utilization, okay? In the beginning, a lot of the nurses were talking about research utilization. We have to use research. But as we have more understanding about what's really important and how we approach care of the patients and research and evidence, it's geared more towards evidence-based practice, okay? So when you say utilization, it's the use of study findings in a practical application, but not necessarily part of a research project. But evidence-based practice is you're using the decision, using the best possible evidence, and you are looking at high-quality researches. We will talk about what these high-quality researches are. Long history, but it didn't start a long time ago, maybe just about less than 50 years ago. And this guy, a British epidemiologist named Archibald Cochrane, kind of was having an out of the box thinking and say, okay, we're doing a lot of these treatments, but the question is, are we supporting this treatment based on evidence, or we're just doing it because the doctors and nurses ahead of us did the same thing? So that sparked this movement towards evidence-based practice. But the very start of evidence-based practice, it started with evidence-based medicine in the 1980s in McMaster University in Canada, when they started to use this terminology and started this movement. And in 1992, there's the approval for funding for Cochrane Center, kind of Cochrane collaboration. Now, if in medicine or in nursing, when you talk about Cochrane, this is they have a website, but this is an organization that puts together a lot of the systematic review. So you don't need to go to each of the journals to find your, the answers to certain research question or clinical problems, but Cochrane makes it easier for clinicians. They put together certain clinical review. They already do the evidence and the appraising, and they just present it, okay? If you go to Cochrane Collaboration, you can see some abstracts, but you need to pay if you want to see the full review. So Cochrane Center is there. It's very useful. A lot of the clinicians and health scientists and professionals go to Cochrane for looking at the evidence. Now for nursing, again, we go back to Nightingale, right? Systematic during the Crimean War, exploring the differential morbidity or mortality among the subgroups, and she presented it to the stakeholders, the politicians, and they made changes. So you can see that evidence is used in practice. So this was kind of a little bit discussed in nursing research. From the conduct of utilization of research in 2006, the National Institute of Nursing Research in the United States published 10 landmark programs. And one of those landmark programs was the research done by Dr. Linda Aiken that I shared a while ago. So there's this saying by W. Edwards Deming, and he is kind of the father of quality improvement, the guru of quality improvement. In big hospitals where there's a quality and safety department, we always use a lot of the knowledge and thinking of W. Edwards Deming. And he said, in God we trust, all others you have to bring the data, okay, so that we can support our decisions and the path forward. So let's look at this definition of evidence-based practice, okay? So one thing that I want you to notice is that evidence-based practice is not just research, okay? Research is part of evidence-based practice, but it's not the only thing, okay? So EBP is a paradigm, a lifelong problem-solving approach. So it's more of an approach to clinical decision-making that involves conscientious use of the best available evidence. Okay? This includes systematic search for and critical appraisal for the most relevant evidence to answer a clinical question. And we'll talk about clinical question in a while. So this is the important thing to remember, one's own clinical expertise. One is the doctors and the nurses, the clinicians, and the patient's value and preferences. And the end result is improving the outcome for the individuals, the communities, or the systems in healthcare. This is from Dr. Melnick and find out. Dr. Melnick is one of the, authorities in evidence-based practice in nursing. So if you look at that definition, there are three main components of EBP. One is the research, which is the best evidence, but it doesn't stand alone. It's the practitioner's expertise that needs to be brought in, nurse, doctor, staff, and the patient's values and preference. Okay? In the hospital where I work in, for example, we have this Da Vinci, this robotic, operation. So there's so much evidence to prove that, there's, healing is faster, recovery is faster, and then the outcomes are best. So no problem about the evidence. But you have to say, okay, there's this Da Vinci, but do we have that equipment? Even if we have that equipment, are there doctors and nurses trained to use that? So that's the bit where the expertise of the practitioners, the nurses and the doctors and the staff is very important. Now, even if you have the doctors and nurses and the best evidence, then you have to ask the patient, is this something that you like or you prefer in your care? Because we need to have patient engagement. So all of these things brought together, this approach is what we call evidence-based practice. Okay? So this is also another way of looking at it. If you see here, we have the research evidence from the researchers, the clinical expertise, for example, from patient assessment as well as healthcare resources, and the patient needs to be involved. All of this will guide the decision making, okay? And of course, what we wanted is the high quality outcome. And all of this, I like this framework because all of this is done in the context of care. And this is the cultural organization that needs to be in place for this to happen. Now, if you look at the models of EBP, there's quite a number of models, and this is just for nursing. Okay, what's very common, Iowa model. I'm very familiar with the Johns Hopkins model because I did a training on this one. But you can see there's a lot of models of EBP. We're not going to discuss a lot of them. I'll just show you the Johns Hopkins model. So in the Johns Hopkins model, if you look at this three here, this is probably what you can see a lot in EBP. There's practice question, and then after the practice question, you have to look at the evidence, and then you translate it into practice. So this will be a continual practice and learn and practice thing. But this does not occur before that comes like the spirit of inquiry within the organization. You need to have an organization that's curious and questioning your practices. Is this right? Are we using the right evidence? Is this the best way to do these things? Okay. And after that, you do EBP projects, and it has to be translated to best practices. And the thing in most hospitals or big in a healthcare organization is always looking at how the practice can be improved clinically, the learning outcomes, and in terms of operations. And when you want practice improvement, you may find some problems again and questions, and then you would go back to inquiry again. So it's kind of a cycle. So this is the Johns Hopkins evidence-based practice model. The Iowa model is probably very familiar. A lot of the professors here at Silliman University College of Nursing use this. There's usually a trigger. It could be a problem-focused or a clinical focus. And then it starts with looking at, is it a priority in the organization? There's some questions, like an algorithm you go through, and you have to make a decision whether you have to conduct the research yourself or maybe just look for the evidence, and at the end you really wanted to disseminate and to make changes in your practice. So this is the Iowa model. You can look at it in the handout that I gave you. Okay, so this pyramid, this is evidence hierarchy and levels of evidences. When you say evidence-based practice, a lot of people are always imagining this pyramid, okay? Because this is a guide for us to look at what are the levels of evidences. One thing that I need to tell you is that not all evidences are created equal, okay? So you can see here the topmost is the best source of evidence, which is level 1, a systematic review or meta-analysis of RCT is your randomized controlled trials, okay? But if you want to go at the bottom here, okay, this is also evidence. They are evidence. but they are probably not the best and strongest type of evidence. This could be non-research source. For example, expert opinion. There's a doctor that has been in this field for a long time, has a lot of opinion, and it is an evidence, but it's probably the weakest evidence there is. And here, a qualitative and descriptive study. Well, a lot of people who are into qualitative research, why are we at the bottom of the rung? It's just that this kind of evidence hierarchy is really biased towards qualitative, and it really favors more quantitative researches. So here there's systematic review of qualitative researches, and then you go to non-experimental, systematic review of non-experimental studies, and then you have quasi-experimental, which is non-randomized trial, and then you have your randomized control trial. Well, we'll talk more about that in the succeeding modules. And here they have the systematic review. So this is a review of the many clinical trials based on a study, and then all their results are synthesized, and it provides the best evidence. Okay, so you can read more about this in the handouts that we have for you. Okay, so what are the major steps in evidence-based practice? So different authors talk about different steps, but essentially these are the basic steps. These are the 5 A's. You ask the clinical question, you acquire the best evidence, and then you evaluate or appraise the evidence, and then you apply the evidence, but you don't stop at applying. You have to assess the performance of the application that you did, all right? So let's start with step 1, okay? Ask a well-worded clinical question. So the very first thing you need to do is a clinical question. But before you can have a clinical question, you need to have triggers or practice question. Triggers, according to the Iowa model, would be like problem-focused triggers or knowledge-focused triggers. Maybe there's something in the clinical practice that probably is problematic and needs some solution. Or maybe you read something in the research literature that says there are gaps to this knowledge, so maybe we'll have to do some evidence-based practice project on this. Or it could be a project question. One time when I was in the hospital, they were saying, okay, we'll do intermittent catheterization, but how long should we clip it, okay? For how long should we release it, okay? Let's look at the evidence. So this is an example of a practice question. So to formulate a clinical question, you can be guided by PICO or PICO, okay? A clinical question should incorporate at least 3 of these elements. These are 4, but if you have 3 of these, that's good. Sometimes they add a T, which is the time bound. So P means patient, I is intervention, C is comparison intervention, and O is outcome. And if you have a T, then that's time bound or time. So for example, the patient. So when you make a evidence-based practice, you cannot cover everything. You have to be able to define the parameters in terms of the characteristic of the patients that you want. For example, are you talking about pediatric patients, elderly patients, what ages, okay, or adults? The sexuality, ethnicity, you have to define. Is it the diabetic patients? Is it cancer patients? Or what other conditions or general health status? And then you talk about the intervention. What are the interventions and therapies that you're interested in? It could be a patient education, a diagnostic, or treatment plan, self-care, or what are other things that you wanted to bring in and to understand. C is comparison intervention. Sometimes this is present, sometimes it's not. A comparison could be another subgroup, a control group, a placebo group, or a different study group. And O, this is very important, the outcome, expected or actual effects on the patient. So this is an example of a foreground question, okay, for using PICO. So the population here, you're looking at adult surgical patients between the ages of 20 and 50 with peripheral intravenous catheter. Okay, so this is your population or the patient, or it could be the problem as well. The I is in the intervention. You're looking at saline flushes, okay? The comparison is the heparin flushes, saline versus heparin for your peripheral intravenous maintenance, okay? What is the outcome you want? You want to look at improvements in IV patency over 48 hours or a decrease in the incidence of phlebitis by 10%. Very, very specific outcome that you look. So if you want to state, you have to have a statement, a clinical question. So it would be like this: for adult surgical inpatients between the ages of 20 and 50 with peripheral intravenous catheter, there's the use of saline to flush the peripheral IV, maintain IV patency, and decrease phlebitis over 48 hours when compared to heparin flushes. It's a bit convoluted, but that's how you do the clinical question. It's not just a very simple one-sentence question, but you need to have the elements of the PICO. If you want T, then that is also good. Now, so that is the P. You have to ask the right clinical questions. The second step is you acquire research evidence. So this is a little bit challenging for us, like in Silliman or in not first world countries, because the resources are looking for this is sometimes really expensive. Good thing that we have Chanell, okay? But in some research facilities or hospitals, or in other universities, they have a huge, database, okay, where they can find researches, like, for example, ProQuest or Ovid or Chanell and things like that. So here's single studies. You can look at Medline. Some of these are free. Synopsis of single researches. You have synthesis, or you can have a synopsis of synthesis, maybe an evidence-based nursing practice. And this is the summaries, okay? Best practices. The British Medical Journal has the best practice. In my hospital in Beijing, where I used to work, we have an up-to-date. It's a software where all of us can go if you wanted to look for the latest evidence. It's always updated all the time, but it's very expensive. There's also, if you want to look at more nursing kind of evidence-based practice articles, you have to go to Joannes Briggs. Joannes Briggs is a collaboration of many organizations in nursing, and you can find evidences there. But the key thing is, this is a little bit expensive, but this is how you can acquire the best evidence. Okay, and then you appraise the evidence. There are so many ways, and you can read more in the handout that we gave you in the PDF, how to appraise the evidences. But basically, you're looking at quality, the magnitude, quantity, consistency, and applicability of those studies. And then you apply the evidences, maybe in your unit. You can go to, let's say if it's ICU, you can talk to the ICU policy committee, practice committee, and you can present your evidence, and maybe it can change your practice. Just like for example, there was one nurse in Johns Hopkins that was looking at how best to take the temperature of patients in mechanical ventilators. So they look at all the evidence, and they found out, like for example, it should not be oral, it should be more, other means, and then they were able to list that down, and then they presented to the committee, and then they wanted to change how they practice and get the temperature of patients who are intubated or ventilated. And then step 5 is to assess outcomes of the practice change. So you can see here the practice question. This is essentially what the Johns Hopkins evidence-based practice framework is, and then look for the evidence and then translate. So you can see here the 5 A's: ask, acquire, appraise, apply, assess. But you can see here there's a 0, which is the EBP basics. And Dr. Malik is really big on this, that the first step, or step 0 in doing an EBP project, is really to have that sense of curiosity or environment within your organization where you're really curious and you wanted to improve and you're asking a lot of questions, right? Because if you don't have that kind of mindset, then EBP will never happen, right? And then when you have that, you're able to do all of these steps in EBP. Okay, so before we close, I'll just show you a few examples of EBP projects conducted by nurses. So I think this is a poster presentation. You can see here bedside shift report. They're looking at the catalyst. What are they asking? Okay, they're looking at how they got into this question. You can see here that they have PICO questions, P-I-C-O, And then how they acquire, they look at different databases like Chanell, Ovid, ProQuest. These are all databases, and these are the search words that they did. Sources of evidence, they looked at mostly systematic review, quasi-experimental, and they also looked at qualitative researches. This is really good. Okay, and then this is how they appraised and looked at the evidence, the quality of the evidence, what they applied, and you can see that they have a timeline of their project from December to maybe a year's time to get this project done. And then they have description, the project, and the cost and benefit analysis, and the outcomes are all here. So that's an example. This one is utilizing transformational models to improve nurse retention. So there's more looking at workforce or human resource management, which is the concern of leadership and administration. So you can see here, they're using the PICO A. You have patient population or the population, intervention, comparison, and the outcome, right? So these are examples of the using EBP projects using the Iowa and the Johns Hopkins model. Okay, so you can see here the different CAUTI reductionist, catheterization associated urinary tract infection, which is a big thing, infection control. That's one of the key indicators that you're doing good infection control in your hospital. And then you can see here just so many other research or EBP projects that you can do. All right. So I think that ends our discussion for today. Thank you so much. And if you have questions, don't hesitate to email me or write me in the forum. And you have forum questions that you need to answer in the Soul Classroom. Thank you very much and have a good day.